Hello, and welcome to the third and final chapter of Lydia Ocampo's story. About a week ago, in the middle of the night, Lydia had a strong urge to urinate. She rushed to the bathroom, but couldn't make it in time and became incontinent. She then slipped on the wet floor and hit the toilet and the tub on the way down. She was rushed to the hospital, where it was determined she had a hip fracture. Surgery was performed successfully, but a week after post-op, her incision became infected and needs to be reopened. Her wound now measures 10 centimeters long, 4 centimeters wide, and 2 centimeters deep. The base of the wound is pale, with yellow exudate covering most of it. There is a large amount of yellow purulent drainage, and the surrounding tissue is intact, but very reddened. Lydia is in a great amount of pain from her wound, which is further limiting her activity level. She is currently taking Vicodin for her pain in addition to her usual meds.
Today I'd like to talk about wounds, specifically post-operative infected wounds. Wounds must satisfy 3 criteria to be considered infected. The first is that microorganisms that are present and invading the tissue must invade the viable tissue. It might be the case that the bacteria or other microorganisms that are present are invading the necrotic tissue or perhaps the purulent discharge, but that alone does not satisfy this criterion. Microorganisms must proliferate to the degree that they impede healing. And third, invading microorganisms must produce a host response. These host responses are erythema, heat, edema, pain, and purulent exudate. You might find it interesting to note that infected wounds are among the most common type of nosocomial infections. An infected wound is a challenge in and of itself to your patient, but under these conditions they are now at greater risk for becoming septic. Sepsis is a system-wide infection of the blood. The bacteria or other microorganisms involved often originate from the wound site. An infected wound most often occurs between 5 and 10 days post-op, but they can occur as early as 1 day and as late as 1 year after the procedure. Wounds can become infected via 4 primary pathways. The first is poor preoperative preparation, wound contamination, poor antibiotic selection, and last, the inability of an immunocompromised patient to mount a successful resistance to infection. At this point, you might begin to ask yourself, what strains of bacteria are responsible for wound infection? Well, there are several strains, but 2 are especially problematic. Those are Staphylococcus aureus, commonly known as MRSA, and Klebsiella pneumoniae. These 2 bacteria are especially menacing because we have few antibiotics left to eradicate them. These patients, for a successful outcome, will require multiple concurrent antibiotics with long durations.
Now let's look at some of the assessment findings for Lydia. First, we will look at the musculoskeletal system. It is important to assess the musculoskeletal system in Lydia's case because of the amount of trauma to her hip caused by the fall and the surgery. We want to make sure that she is healing well without any problems. We would find that Lydia's strength and range of motion to be decreased in her lower left extremity due to her pain and swelling. The rest of her limbs shouldn't present any abnormalities. Next is her neurological system, which is important to assess because of her history of dementia and Alzheimer's disease. We would see an impairment of her level of consciousness because of her pain medication, and we would also see an impairment of many other cognitive functions and a low score on the mini mental assessment because of her Alzheimer's. One thing we would pay special attention to is any numbness or tingling around or below the surgical site, as this may be an indicator of a deep vein thrombosis, which are common after orthopedic surgeries. Lydia's skin should be assessed because of her wound and her risks for further skin breakdown. Upon assessment, we would find an infected wound with yellow exudate on her left hip. We would also find swelling and redness near the wound. We would also find that she is at high risk for skin breakdown with a Braden score of 14. Her incontinence, level of activity and mobility, and poor nutrition all contribute to her low Braden score. Because of her lack of activity and increased nutritional needs for wound repair, It is important to perform an abdominal and nutritional assessment on Lydia. Upon auscultation of her abdomen, we would find decreased or absent abdominal sounds because of her inactivity and pain meds. We might also see distension of her abdomen due to constipation. We would also note that Lydia appears underweight and that she is refusing to eat without her husband present because of a delusion that the hospital is trying to poison her. And here's Lydia's updated concept map, which includes altered tissue integrity related to her hip surgery and risk for dysfunctional gastrointestinal motility related to her immobility. Josh will now talk about these two NANDAs in more detail. Josh?
Let's discuss our plan of care to prevent bowel issues for Lydia. Our NANDA is risk for dysfunctional gastrointestinal motility related to immobility. Our first knock is Lydia will be free from abdominal pain while in the hospital. Our nicks include palpating for abdominal distension and pain, auscultating for normal bowel sounds, positioning her into a comfortable position, preferably one that allows for her to have a bowel movement, such as elevating the bed to 30 degrees if she can tolerate it. We check for impaction and if possible remove it as ordered. We'd also apply a heating pad to her abdomen in order to increase her comfort level. Our second knock, Lydia will maintain an adequate diet during her stay in the hospital without nausea and vomiting. Our nicks include assessing for nutritional deficits by assessing her skin turgor, hair texture, and obtaining lab values. We'd assess for nausea and vomiting after each meal. We'd encourage fluid intake to ensure adequate hydration, and we'd encourage a diet consisting of several small meals per day. We'd also obtain her medications, making note of any medications that may possibly interfere with GI function. For example, she's on morphine, an opioid, and promethazine, an antiemetic. Both decrease GI motility, putting her at risk for constipation. However, Donepezil, which is indicated for Alzheimer's, and Ansef, which is an antibacterial, both increase GI motility. So in this situation, we'd want to give her the lowest effective dose if possible regarding these medications. And if we had any concerns, we could always call pharmacy and notify the physician if we suspected any problems with constipation for Lydia. Our third knock, Lydia will have a bowel movement either every day or every third day. We'd monitor and record daily fluid input and output, assess for signs and symptoms of delayed gastric motility, for example, nausea after eating, vomiting, heartburn, bloating, and we'd encourage a diet high in fiber. We'd also try to create a bowel routine, giving her constant reminders after breakfast and lunch and dinner to use the bathroom. We'd also administer medications as ordered, indicated for constipation if we had to. For example, we could give a stool softener such as Colace. Now let's discuss the care plan to reduce pain and increase mobility for Lydia. Our NANDA is acute pain related to a wound incision as evidenced by her statement of pain. Our knock is that she will either state her pain as 3 out of 10 or less, or have fewer complaints of pain because she's unable to communicate with us all the time. And we'd want this to be done within 12 hours. Our NICs would include administering pain medication as ordered. For example, 2 to 4 milligrams of morphine IV every 1 to 2 hours as needed, and 650 milligrams of Tylenol every 4 to 6 hours as needed. We'd assess her pain level before and after giving medications. We'd also apply a heating pad to her hip or area of pain, and we'd try to provide a comfortable environment to reduce anxiety. For example, we would dim the lights, make sure it's not too noisy, and try to make sure her husband is around. This is because anxiety can exacerbate pain. We'd also use distraction techniques to keep her mind off the pain, and we'd use Danilo to help us. We could also use games and puzzles to keep her occupied. Our second knock is increased participation in activities of daily living within 3 days. We'd assess Lydia's pain level using the 10-point pain scale before performing activities. We'd administer pain medication as ordered before performing these activities. We'd also encourage her to sit in the chair at least 3 times a day. And we'd increase her activity level as tolerated. For example, we'd want to get her from the chair to perhaps short walks every day. We'd also assess her pain, including the location, character, and duration after each activity. We'd probably need the help of Danilo to do this. Our third knock is that Lydia would not show any pain-related behaviors, including guarding, facial grimaces, or moaning. Our nicks include teaching relaxation techniques, such as deep breathing exercises. With the help of her husband, we'd monitor her vital signs every 4 hours. We'd provide adequate time for her to rest between procedures, and would give the lowest effective dose of pain medication to prevent any liver failure or toxicity. We'd also teach Danilo pain-relieving techniques that he can provide to Lydia, such as ways he can provide distractions.